Thank you so much, Dr. Nikhil, and thank you for inviting me to give this talk at this session. So cicatrizing conjunctivitis results in severe dry eye, end-stage ocular surface disease, and permanent corneal blindness. Now, why is it important to diagnose these entities early? Because in the chronic phases, they all look the same. They are indistinguishable. The treatment in end-stage disease is type 2 K-Pro, which is very difficult to manage, as we all know. And some of these conditions also have significant systemic morbidity. So for all these cases, it is very important to examine the tarsal conjunctiva very well and also look out for this very characteristic subepithelial fibrosis on the tarsal conjunctiva, as can be seen in this eye. Sometimes it can be subtle, still significant. These are all cases of biopsy confirmed mucous membrane pemphigoid. And this is very typical, the lacy kind of fibrosis that you see in MMP. And second, we need to examine the fornices, especially the inferior fornix, because in this case, this is again a biopsy confirmed case of mucous membrane pemphigoid picked up very early. You can see the fibrosis here in the inferior fornix. This is not normal. You can also see medial and lateral canthal fibrosis. This is a bit more advanced than the last case. Again, should not be missed, can be very easily missed during our routine examination on the slit lamp, but I always make it a point to examine the inferior fornix in all cases so that I know that when it is very subtle and I can still pick it up. Sometimes it can be only limited to the medial area. And again, examining the lacrimal gland is something we do not do, which is a bit not intuitive, because these are all cases of dry eye and they're all because of some lacrimal gland pathology. So it's very important to examine the lacrimal gland, something even we have learned in the last 1 or 2 years. So in the upper images, you can see these are all normal lacrimal glands. They are pink, they are very convex in shape. They prolapse out when you retract the superior-temporal eyelid. And these are cases with a normal Schirmer's, as can be seen here. However, these are cases of cicatricial dry eye, MMP and SJS. You can see there is fibrosis here. The lacrimal gland is not pink, convex. And there is a synechia here in the area of the lacrimal gland, which corresponds to what the Schirmer's is in this eye. Again, complete fibrosis, cannot see the lacrimal gland clearly. Schirmer's is 0. Here, there is one normal area. The rest of the gland is fibrosed. Also, it is it's very beautiful to examine the tearing that happens from these lacrimal glands. You can just use a fluorescein strip placed here when you're looking at the lacrimal gland on the slit lamp. And in normal cases, you see about 2 to 4 ducts which are actively secreting tears. And these are seen very beautifully. However, in cases of cicatricial dry eye, as you can see here, there are no ducts releasing these tears. So we have published this last year in 2 papers in the British Journal of Ophthalmology. In one, we have described the anatomy of the normal lacrimal gland and how to examine it in normal versus dry eyes. And in the second, we have described the tear secretion from the lacrimal gland. So I'll be discussing 2 cases and mainly to show what are the most common cases of cicatricial dry eye that we see in our clinics. So this was a 76-year-old female from Hyderabad, housewife. Came to us with left eye irritation, foreign body sensation since 2 months, diagnosed previously as dry eye disease and was only on lubricants. As you can see here, the lid margins are rounded. The lid margins did not have any other pathology other than meibomian gland disease. However, she had this very strange medial canthal shortening or fibrosis. She had very subtle tarsal subconjunctival fibrosis on the tarsal conjunctiva, as can be seen here. And again, very subtle fibrosis in the inferior fornix and some folds that could be seen and some amount of shortening. When we stained the ocular surface, there were diffuse SPKs all over the cornea. The Schirmer's was 3. So the provisional diagnosis in this case was a left eye chronic cicatrizing conjunctivitis, severe aqueous deficiency dry eye with pseudophakia. Now, like Dr. Hijab alluded to, this was a paper we have published in IJO last year, where we have discussed all the differential diagnosis of chronic cicatrizing conjunctivitis. So there are multiple causes, and we slowly need to find out how to rule out all these causes because they all present in the same way. This is a beautiful series of images from Dr. Dart's very seminal paper, on cicatricial conjunctivitis, where the findings are the same in all these eyes. However, the etiology is different in every single eye. So it shows us there is so much that we need to rule out in these kind of cases, and it can belong to any one of these entities. So coming back to the algorithm that Dr. Hijab showed from our paper, we asked all these questions to the paper and to the patient, and we ruled out all these common etiologies such as thermal burns, chemical burns, radiation, GVHT, drug-induced cicatrizing conjunctivitis, pemphigoid rosacea. And we finally came to the important question of, is there any history of skin or mucosal involvement in the past? Now, this patient did not give any history of skin or mucosal involvement, which can still be mucous membrane pemphigoid or some other autoimmune entity. So we did a serological profile, which all came back negative. RA factor, ANA, both were negative. And then we decided to do a conjunctival biopsy. We take a biopsy from both eyes, and we send the biopsy to both histopathology and diffuse immunofluorescence. Michel's transport medium is something that can be used probably in private practice because logistically it might give you more time to send it to the pathology lab. And on immunofluorescence, we typically see this positivity at the basement membrane because of deposition of immunoglobulins and complements. So her biopsy was positive, and the final diagnosis was mucous membrane pemphigoid. The right eye was perfectly fine for this patient. About 20% of cases of MMP present only with unilateral involvement. However, we have to keep a close watch for the other eye also. It may soon develop the same condition. So the treatment was mainly, this algorithm is again given in our paper. And because this is progressive cicatrization, the main treatment here is systemic immunosuppression. So we did baseline investigations and started her on oral cyclophosphamide. Very important to even counsel these patients as to why you're doing this, because in early cases, they do not have that many symptoms, but you have to sit with the patient and actually tell them what is happening, what might happen in the future if you do not start oral immunosuppression, and the possibility of corneal blindness. We closely monitor the ocular surface on every 3-month visit, also do blood investigations every 3 months because she's on systemic immunomodulators. And we treat it with topical lubricants, mainly topical steroids only if required. This is Foster staging system. So in stage 1 and stage 2, these are the main stages where we need to pick up these cases rather than let them progress to stage 3 and stage 4. This is a typical case of mucous membrane pemphigoid, came to us in the acute phase with bilateral cicatrizing conjunctivitis, typical palatal ulcer, oral lesions on her skin. But this is rare. We do not see such typical cases of mucous membrane pemphigoid because they do not come to us sometimes in the acute phase, and they come to us multiple years down the line. So very important to pick this entity up early. So history taking slit lamp examination is extremely important, and we should always practice a low threshold for conjunctival biopsy, especially when it's possible in a tertiary center like ours, to prevent cornea from going from this to this. Now I'll talk about case 2. So this was a 36-year-old female from West Bengal, both eye blurring since 12 years after an episode of chickenpox. As you can see here, the right eye is more affected than the left eye, but she has this pillar-like foreshortening in both the medial and the lateral canthus. She has, the lid margins look grossly normal with no keratinization at least, although the meibomian glands are completely blocked. And the inferior fornical shortening is very gross. She has LSCD, corneal vascularization, dystichiatic lashes, and as can be seen here. Schirmer's is 4 in this eye. Left eye, again, very similar findings, but the cornea is much better, and the Schirmer's is 5 in this eye. So again, a diagnosis of chronic cicatrizing conjunctivitis with right eye partial LSCD. Again, we went to the algorithm, asked for all the history, and she gave history of skin and mucosal involvement with hospitalization about 12 years ago. And then we do something that we have formed, which is the SJS scoring. This is again published in the British Journal of Ophthalmology last year. And what we do is we take a very good medical history and we do a very good clinical examination to mainly come to the diagnosis of SJS. So skin discoloration, disfigured fingernails or toenails, posterior migration of the mucocutaneous junction, lid margin keratinization, dystichiasis. All of this gives us 1+1 point in the scoring system, and medical history is again important. So in the medical history, if the patient gives history of sudden onset of conjunctivitis associated with peeling of skin on pressure, associated with loss of nails in the acute phase from the fingers and the toes, with hospitalization for a long time during this episode, these were all the history that the patient gave us. And with clinical examination, she had disfigured fingernails and toenails. She had posterior migration of mucocutaneous junction in the mouth, no lid margin keratinization, but she had distichiasis. So for her, the scoring came to +7. And if it is more than 5, we come to a diagnosis of Stevens-Johnson syndrome. If it's less than 5 or equal to 5, we tend to go towards a diagnosis of mucous membrane pemphigoid. Now, because she's Stevens-Johnson syndrome, we do not do a conjunctival biopsy in these cases unless there is a clinical suspicion of something else happening. And at the same time, what is the treatment algorithm? Because she did not have lid margin keratinization, we did not do a lid margin MMG, but she has dryness and keratopathy, for which we do give scleral contact lenses. So scleral contact lenses, we were unable to fit in this eye because of fornicial shortening. And that's why we did mucous membrane grafts over the bulbar surface, and then there is scleral lens fitting after 2 months. And now the patient is very comfortable. So again, history taking, general examination, slit lamp examination, scoring systems are all very vital to reach an etiological diagnosis. This was a case where somebody...
Sorry to interrupt, doctor.
Yeah, I'll be just finishing.
We are running very short of time.
Yeah, so this was a case which presented to us having undergone symblepharon release and AMG elsewhere. And this was actually a case of MMP, misdiagnosed as herpes. And this went on to become this. So we need to be very good at diagnosing these disorders. So again, detailed history taking, meticulous clinical examination, complete autoimmune workup, conjunctival biopsy, and evaluation for systemic involvement to initiate immunosuppression is very important. If any doubt clinically or an equivocal SJ score, then a conjunctival biopsy should be done in these cases. I have a few slides on treatment, which I'll not allude to because this has already been covered. I would like to thank my colleagues and the ocular surface team at LVPI. Thank you so much.